Everybody, and we've got another great case from ELSA this week. So this is the 3-year-old neutered female Maltese Terrier which presented with a 2-week history of intermittent yelping and 2-day history of progressive tetraparesis. So we'll have a look at the MRI now. So we'll start with the cervical spine, and I like to start with the sagittal plane images, which allows us to assess the alignment and diameter of the vertebral canal. We see the bones very nicely on the T1 weighted image here. We see on the bottom here we can see the vertebral bodies in the lamina, and so I like to look at the alignment. Is there any subluxations, etc.? Do we have any signs of osseous stenosis? So here we see that it's relatively normal in alignment and diameter of the vertebral canal. On the T2 weighted images, we can see that the intervertebral discs are relatively non-degenerate. So we have the normal T2 hyperintense nucleus pulposus within the discs, so they're hyperintense here. So they all look fairly unremarkable, and no signs of discal herniation. In these small breed dogs, this kind of appearance to the dorsal annulus would be normal. However, the striking abnormality in this particular case is the quite extensive areas of abnormal signal best seen on the T2 weighted images within the spinal cord. So we can have quite extensive intramedullary, slightly heterogeneous T2 hyperintensity, most severe cranially here from C1 to about C4-5, and less severe changes in the craniothoracic region. We see on the T1 weighted image that the area of abnormality, quite severe swelling of the spinal cord. So we can see this loss of subarachnoid space and epidural fat, so quite a lot of swelling associated with this parenchyma. The other thing which, if we have a look at the caudal fossa, is that we appear to have an abnormal conformation. So there's some changes here in terms of the osseous conformation to the caudal cranial fossa. Some brain images in this particular case as well, and we can see better the caudal fossa abnormalities in this particular case. So if we have a look here, we can see the arch of C1, which extends rostrally ventral to the ventral surface of the supraoccipital bone. So we have this abnormal indentation of the ventral part of the cerebellum. So this would be consistent with occipital-atlanto overlapping. The supraoccipital bone also appears slightly hypoplastic, so it's quite small, and we have really vestigial or kind of reduced size of the osseous tentorium cerebelli. So we have a caudal fossa malformation. The ventricular system in this particular case looks slightly distended, so we have a degree of distension of the third ventricle and suprapineal recess here. The mesencephalic aqueduct and fourth ventricle are also slightly distended, as are the lateral ventricles. However, we don't see really any compression of the adjacent parenchyma, a degree of distortion of the sulci, but we still have CSF within the sulci, and we don't see, it doesn't really have a kind of turgid appearance that we see when we have obstructive hydrocephalus. Additionally, there are some signal alterations within the brain parenchyma, so there's a subtle area of ill-defined T2 hyperintensity in the caudal brainstem here. And if we look very closely in the brain, we can see within the white matter of the cerebrum, there are kind of small areas of ill-defined T2 hyperintensity, so quite subtle changes, but we have some multifocal areas of signal change within the cerebrum and brainstem. If we look more closely at the spinal cord pathology, here we have the transverse T2 weighted image and the sagittal. So we can see at the level here of mid C2 that the changes are very extensive, involving almost the entire cross-sectional area of the spinal cord, which is markedly swollen. We have a degree of asymmetry of the cord, so we can see that the right side here is more severely affected with the displacement of the central canal towards the left, and this swelling of the grey matter, which is deforming and distorting the adjacent white matter. So the signal changes are involving both grey and white matter. So we see here the kind of central grey matter, this normal butterfly, which is diffusely hyperintense, but there's also quite extensive involvement of the white matter as well. And then we have dorsally within the spinal cord at this level, we have this slightly plaque-like area of lower signal that appears relatively broad-based. So we can see it here very nicely on the transverse plane images. So quite extensive changes in the cord. So this is one case where we would definitely want post-contrast images, particularly given the signalment and clinical findings and the MRI appearance. Once we have a degree of caudal fossa malformation, the cord changes aren't really typical of syringomyelia, and we have obviously the multifocal areas of signal changes in the brain, plus this abnormal plaque-like appearance to the spinal cord. So we can't really attribute these spinal cord changes to the caudal fossa. So in this particular case, the post-contrast images show really quite striking changes. We have very dense enhancement of this abnormal tissue dorsally within the spinal cord. It appears to be genuinely within the spinal cord rather than some form of intradural extramedullary mass. So we can see this really dense homogeneous contrast enhancement within the dorsal aspect of the spinal cord. And then additionally we have quite more extensive meningeal enhancement, so we can see enhancement of the meninges surrounding the spinal cord. You need to be slightly careful about assessment of enhancement, particularly in the cervical spinal cord, because we have, obviously we would expect to see normal enhancement of things like the vertebrovenous sinuses, which in the cervical spinal cord cranially will encircle the cord. But here we can see this is a genuine meningeal enhancement. Additionally, we have at the level of C1-2, we have this enhancement and swelling in the region of the roots or the proximal parts of the C2 nerves. The post-contrast images also show mild meningeal enhancement adjacent to the cerebellum, so we can see the meningeal enhancement here and this abnormal enhancement of the meninges caudally adjacent to the cerebellum. So in this particular case we have numerous abnormalities, the most significant being the extensive intramedullary T2 hyperintensity with swelling within the cranial spinal cord, which showed quite extensive abnormal intramedullary and meningeal contrast enhancement. We additionally had multifocal areas of T2 hyperintensity within the brainstem and cerebrum and mild meningeal enhancement. There was also mild swelling and contrast enhancement of the C2 nerves and incidental chiari-like malformation and occipital-atlantal overlapping. So in terms of the differentials in this particular case, for me the primary differentials are really quite limited. We've got inflammatory disease, so meningeal encephalomyelitis, of which immune-mediated disease is probably the most likely. However, we can never really exclude infectious disease, although that would be quite rare in the UK. So further testing there would really be required. We should also consider round cell tumour, which can resemble inflammatory disease, particularly when we have nerve root involvement. So that's we'll often see that with lymphoma. So in this particular case, I think we should be considering lymphoma or other round cell tumours such as histiocytic sarcoma. So putting it all together, I think given the history and the signalment, we would be more suspicious of meningeal encephalitis rather than round cell disease, but additional testing would really be required in this case to determine the etiology. So hopefully you found that interesting, and we'll look forward to hearing the outcome from the case on ELSA on Friday.